We wrap up Disc 1 with a discussion I had with Dr. Clyde Yancy, the Magerstadt Professor and Chief of the Division of Cardiology at Northwestern Memorial Hospital and Northwestern University Feinberg School of Medicine, on biomarkers versus clinically guided heart failure care. Systolic versus diastolic dysfunction. Where are the gains? So let me first welcome you to ACCEL, and let's discuss this issue of biomarkers and the clinical assessment of heart failure. I think it's a really important topic with the number of patients that we see with this disorder.
The discussion that is prompted by this great ACC New York Cardiovascular Symposium that Val Fuster is leading is one that we presented earlier, which was how do we navigate the potential benefit of using biomarkers to help us better refine medical therapy versus clinical judgment? Are there substantive gains using biomarkers as we attempt to titrate medicines for heart failure? I'm going to tell you up front, the short version is maybe. Now, I know that's not an earth-shattering answer, but the more provocative answer is that, you know what? Good clinical judgment that smartly uses evidence-based, guideline-driven care is hard to beat. And I think if we start from that premise, making the right assessment, following the evidence, and being guideline-driven, you're going to do pretty well by your patients. And whether or not bringing any other tool in the mix, including a biomarker, is going to make a profound difference may be very much subject to which patient population and under what circumstances.
One of the things that we're seeing over time is a little less reliance on physical examination and history taking, even at the educational level for medical students and residents. And I'm hearing you say that that's an important thing in managing heart failure. So what's your sense? I mean, the first thing you do is do a BNP with these patients. How do we teach our young people to assess the patient at this point?
So, Fred, you've identified two dynamics that really require us to put some brakes on these shifting sands, if you will. We ought not allow the skill set at the bedside to be subjugated by the convenience of a test. Nothing can supersede clinical judgment when applied correctly in the construct of good training to understand this is an elevated neck vein, this is an S3, these are warm extremities or not. So we need to preserve that clinical exam finding because all the evidence we have about the benefit of biomarkers is really couched in that group of patients where there's either clinical ambiguity about the assessment or there is a necessity to go beyond how the clinical assessment would otherwise inform you. So that's the first thing. The second thing is that we also have to put brakes on this other shifting dynamic, this other shifting sand I mentioned, and that's this eagerness to go ahead and get the biomarker assay in every scenario because it confounds your decision making and it puts you at risk for making decisions based on a test result, not based on a clinical assessment. It's really, really important for those listening to use the biomarker in the right setting to facilitate, not complicate your decision making.
One of the things I think we all begin to understand is that, let's take BNP as a typical biomarker, is that there's an awful lot of people without heart failure that have elevated BNPs, and that can certainly confuse the issue, number one. So I think your point is when there's clear-cut confusion, somebody with bad COPD who has dyspnea and you're not quite sure, right. Sometimes it's helpful there. What's the approach?
Let's talk through the scenarios. Very quickly, if you're in the emergency department and there's ambiguity, BNP or one of the newer modalities, very beneficial. What about in the hospital? We don't have data yet to suggest that you should follow the BNP on a daily basis, but we do know the admission BNP when it's elevated predicts events, rehospitalizations, mortality, and especially the pre-discharge BNP is very important prognostically because it anticipates about an 80% likelihood of a return visit, hospitalization, or death if that pre-discharge BNP is greater than 800 picograms per ml. So that's a take it to the bank set of statements. The next question is, can you take the BNP into the outpatient setting? Will it help you identify a better strategy to monitor and titrate therapy? So the word strategy is important here because we're no longer talking about a medical intervention. We're talking about a strategy intervention. It's very hard to test strategies, as you know. It's very hard to do randomized trials where you do one thing for a group of patients but not for the other. But again, to really distill this down, we reviewed data earlier today from the TIME CHF trial where maybe there's a benefit, small group of patients, a benefit for those less than 75. Those over 75, maybe the effect was neutral. The benefit for those less than 75, perhaps on overall mortality, heart failure, event-free hospitalizations were reduced as well. But one has to worry about an overzealous adjustment of medications in patients greater than 75. At best, no benefit. At worst, maybe a signal that we're not comfortable seeing. Contrast that with another data set we reviewed by Dr. Jim Januzzi and his colleagues at the Mass Journal, Protect HF. The Protect study was a great study because it showed what happens when an engaged group of practitioners are partnering very good clinical assessments with the strategic use of a biomarker in a very select patient population enriched by those who had already had an event. Here's the important take-home message. Right now, Fred, as we speak, there's no guideline recommendation to incorporate BNP or other biomarker-guided therapy as a standard of care. But it is intriguing that some data sets are emerging, maybe in younger patients treating to a threshold reduction in BNP, particularly in those who've had an event where it could add something to it. But again, it's all in the background of good clinical judgment. Anybody who thinks that this is the short circuit to saving money and using mid-levels and letting physicians do other things probably oversimplified the space.
So conceptually, and I'll talk about heart failure patients leaving the hospital, probably 60 or so % of them, at least in our institution, are handled by hospitalists and not by the cardiology team. I think the message with BNP as a marker for better discharge history really is telling us that we got to do a good job taking care of the patient in the hospital. We have to have clinical judgment. We have to have biomarkers. I'm still a fan of the scale, and I keep talking about gravity doesn't change very much, so you can use that. If we use whatever markers, clinical biomarkers, to know when the patient's ready to be discharged, we're going to have a better outpatient experience. So you have a BNP that's elevated, and your utilization people come around and you say, look, this patient isn't ready to be discharged. And they'll say, well, the respiratory rate's below 20, so we can send them home. That's, I think, where we need to go with the clinical data and the guidelines, because there may be good uses for the biomarkers in terms of prognosis, both going in and going out of the hospital. Even now, what's your perception? How do you decide when a patient's ready to go home when you have to fight with the utilization people all the time?
A couple of quick points here. I think you really have driven down to a very important concept. I don't know why we never embraced the prognostic information in BNP as avidly as we did the diagnostic utility. And we've kind of leapfrogged the prognostic information and we're looking at the management applications. I think the prognostic information is profound. If you look at the BNP as a standalone RNT, pro-BNP added to something like lectin-3 or maybe ST2 that's coming along, the prognostic information is very, very powerful. And so if it's important to discriminate patient groups and understand who's high risk and low risk, we're missing an opportunity. So I'll leave that as a standalone statement. I think your insight about hospitalization and timing of discharge is really important, because what you really are getting at is that part of our readmission conundrum right now is arbitrary. We've created it because our length of stay in this country, approximately 4 to 5 days, is exactly in keeping with reimbursement. And if you look at Europe, you know the European theater much better than I. The length of stay there is about triple what it is here, but the readmission rate is about 60% or less of what we are doing. There's no free lunch here. Either you keep people in the hospital until they're well and they don't have to come back as often, or you send them out when they're still ill and expect them to return. And so now when they return, we were imposing penalties for that, when in point of fact, by whatever standard, by weights, by neck veins, by biomarkers, they weren't ready to go home to begin with. How we change that whole model is unclear to me, but I think we have to start to think about some definitive ways to say this is or is not a good moment to discharge someone, and not let it be perceived as a penalty because someone's in the hospital an extra day or two to really get to where they're better. We shouldn't treat the BNP. We have to treat the patient. But I think when we're sending patients out with very high biomarker assays, and, you know, we were part of the ADHERE program, helped to lead that years ago, and our data were amongst the first to show that the minimum weight change was almost zero. The delta was almost zero across the entire population. We're missing the mark there.
I think you're bringing some new concepts here, or at least reiterating things that we should know to manage patients in the hospital and the transition. I think part of our problem has been that the responsibilities have been siloed in different areas, so there hasn't been much transition. This new effort by CMS to penalize us if we don't do our job right is bringing the silos together a little. Let me thank you for being here at ACCEL. I think this is an ongoing topic. I'm sure we'll get you back here again to review this as we move forward with new biomarkers and hopefully better ways to educate our young physicians on how to assess heart failure. So thanks again. As I said, we'll see you again with this topic another time.
Fred, I'm delighted to be here and happy to work with you.
And that concludes Disc 1 of ACCEL. For details about studies discussed, revert to the written summary that is included as a PDF file on Disc 3. Disc 2 begins with a discussion of severe aortic stenosis.